The next speaker, Professor David MacDonald, is the head of a section of neurophysiology at the Department of Neurosciences at King Faisal Specialist Hospital and Research Center in Riyadh, Saudi Arabia. He is the former president of the International Society of Intraoperative Neurophysiology, and he's also the first author of the recommendations for intraoperative somatosensory evoked potentials, and this will be his presentation. Professor MacDonald.
Well, I thank the organizers for this invitation to speak. It's my honor. And the topic is recommendations for intraoperative somatosensory evoked potentials. This was a work that took about 4 years. We published it in 2019. And there are two main new recommendations that I'd like to highlight. The first is SCP Optimization to enhance surgical feedback speed and accuracy. And the second is an adaptive warning criterion to adjust for baseline drift and trial-to-trial variability. SCP Optimization was developed in a series of 8 investigations that I undertook personally in the 2000s, early 2000s, and they included prospective study. And the technique maximizes the signal-to-noise ratio to minimize the amount of averaging and also maximize reproducibility. It emphasizes total intravenous anesthesia to enhance the signal-to-noise ratio of cortical responses. And it selects the fastest reproducing highest SNR derivations for monitoring while omitting slow, low SNR derivations such as subcortical SCPs. It also includes decussation assessment and supersedes traditional methods that accept slow, low SNR derivations and assume decussation, thereby missing rare non-decussation. Tibial nerve optimization is quite straightforward. We use the popliteal fossa potential as a peripheral control. This is a high SNR signal, and 0.2 to 1000 hertz bandwidth is the appropriate setting to use. And then the highest SNR cortical monitor recorded with a 30 to 300 hertz bandwidth. These are the possible optimal derivations for each tibial nerve. CPZ to CPC. CPC is either CP3 or 4 opposite the stimulated nerve. This derivation is optimal for 40% of tibial nerves approximately, but any of the others could be optimal in any one individual. And so the best approach is to determine the optimal derivation from a post-induction comparison that I'll show in a moment. And this comparison also assesses the patient's sensory decussation. If you rarely encounter non-decussation, then of course the lateralization of these derivations would be reversed to properly record the potential. Now, just an illustration of the importance of a peripheral control for SCP monitoring. The middle trace is the tibial nerve P37 cortical response. The right trace is the tibialis anterior muscle MEP. In the right leg, and these disappeared during this thoracic surgery. So this would raise the question of whether there's a surgical problem with the spinal cord. But the disappearance of the right popliteal fossa potential clearly indicates the problem is distal to the knee. So there's no surgical alarm here. And this is typically due to distal conduction failure. In the legs, it's most often related to ischemia. And I suspected that the pelvic support might be compressing the femoral arteries and leading to ischemia of the limb. And so we repositioned the pelvic support under this prone patient, and that restored perfusion in the limb and all the potentials. So the peripheral control is very important to avoid a false alarm in this kind of situation. And conversely, if the peripheral potential is preserved, then one can immediately exclude a distal limb problem and go directly towards diagnosing the problem that the surgery is causing in the spinal cord. These are the electrodes that one needs to place in order to do a full optimization of the tibial nerve SCP. There are some additional electrodes to the standard complement, and there's 4 extra ones, but it's worthwhile because of the superior results. This is the optimization recording, which is done simultaneously. The referential recordings on the left, one looks at these to see the site of the optimal, the largest P37 cortical response, which was at CZ on the left and CP2 on the right in this particular patient, and find the contralateral scalp N37 potential, usually at the contralateral scalp, that is. This is a good input too for the monitoring derivation because the N37 gets inverted in the differential amplifier, which adds to the P37 and increases the signal-to-noise ratio. We also look at the lateralization of the P37 field, which is highlighted in the dashed rectangles. And it should be ipsilateral to the stimulated nerve, which was the case in this patient. So we have an ipsilateral P37 field and contralateral N37 potential. This demonstrates normal decussation. So we're not assuming it, we are demonstrating it. And then the bipolar recordings assess all of the possibly optimal derivations for monitoring, and they confirm that CZ CP4 on the left and CP2 CP3 on the right will be optimal for monitoring this patient. They'll provide the highest signal-to-noise ratio and fastest surgical feedback. And notice that they're quite superior to the standard commonly recommended CPZ to FPZ derivation. The technique can be reduced to 8 or 16 channels by simply recording CP4 and CP3 to a mastoid reference, and then the 6 candidate derivations of each side. And in this patient, the CP4, CP3 recordings demonstrate the lateralization and the decussation, and the bipolar channels identify the optimal monitoring derivation for this patient, which was CZ to CP4 on the left and CZ to CP3 on the left. Now, if you encounter a recording like this, you have a patient with sensory non-decussation. The P37 field is contralateral to the stimulated nerve, the N37 is ipsilateral. This occurs with a rare anomaly called horizontal gaze palsy and progressive scoliosis. These patients do come to scoliosis surgery, and if you don't look for this anomaly, you won't find it. CPZ to FPZ alone will not pick this anomaly up. You'll have inaccurate monitoring. For median nerve SCP optimization, the cubital fossa is the peripheral control. It's a very high SNR signal, the same filter settings as the popliteal fossa, and the highest SNR cortical monitor with 30 to 300 Hertz bandwidth. These are the 3 possible candidates. CPC to CPZ is optimal for 75% of median nerves, so I just use it routinely, and I might check the other 2 if it seems possibly suboptimal, but you can also compare the 3 and choose the best one for monitoring. And if not already done with tibial nerve SCPs, which I usually do, you can do coronal recording to check decussation. And if you get rare non-decussation, you reverse the derivation lateralizations. This is a cubital fossa. It's the exact analog of the popliteal fossa, and panel B shows these in single sweeps. These are extremely high signal-to-noise ratio signals that do not really require averaging. We average them because we're already averaging the cortical response, but it's just to illustrate how high the signal-to-noise ratio is. And again, their use for monitoring purposes in panel C, the cortical SCP from the median nerve is lost during a cervical surgery. So it would beg the question of whether it's a surgical problem, but the disappearance of the cubital fossa potential shows it's distal to the elbow. And in this patient, there was a shorting of the stimulating electrodes because of leakage of blood from the arterial line. So we've repaired that and reapplied the electrodes in a dry manner and restored the potentials, avoiding a false alarm with the peripheral control. On the right side, there was a loss of the cortical median nerve SCP and a reduction of the thenar muscle MEP, again raising the question of surgical injury to the cervical spinal cord. This was a cervical surgery, but the cubital fossa potential had disappeared. Now, this was due to ischemia of the limb. The shoulders had been pulled down with strapping to increase cervical exposure, and I reasoned that there might be compression of the thoracic outlet arteries, and so we released the shoulder strapping and the potentials returned with no false alarm. Again, if the peripheral potentials are preserved, you can forget about any problem with the distal limb and proceed directly to surgical interpretation. So they're critical for monitoring. This is an example of a patient with sensory non-decussation with median nerve stimulation. You can clearly see the cortical N20 potentials are arising ipsilateral to the stimulated nerve. So you'd need to use reversed lateralization monitoring derivations for this patient. If you use a standard CPC-FPZ derivation by itself, you will not detect this anomaly because the P22 from FPZ will become inverted in this derivation. It will mimic a small N20, and you'll have absolutely no idea that the patient has sensory non-decussation, and you'll simply provide suboptimal inaccurate monitoring. Does it really help to do this? Well, yes, it does. The left side shows the optimal two derivations for median nerve monitoring, for example, and they show high reproducibility in only 50 sweeps. That only takes a matter of seconds, depending on the stimulus frequency. On the right are the traditionally recommended monitoring derivations. The cortical channel did not too badly, but required about 4 times as much averaging to get the same degree of reproducibility. And the other 3 subcortical, cervical, and Erb's point derivations required 1,000 sweeps to get satisfactory reproducibility, and that would take several minutes, which is unacceptable for surgical feedback. So it does make a big difference to do optimization of SCPs. This is a plot of over 500 SCPs recorded with various recording derivations to see how much averaging you needed to do to reproduce them according to their raw signal-to-noise ratio in the x-axis. The left y-axis shows the number of sweeps required to reproduce, and the right y-axis is the corresponding number of minutes at approximately 5 Hz stimulation, presuming there are no other interruptions. And you can see that in the red zone below -10 decibels signal-to-noise ratio, there's a very rapidly increasing amount of averaging that one has to do. And below -20 decibels signal-to-noise ratio, just forget it. You're not going to get a reproducible response. And unfortunately, this is where most of the traditionally recommended derivations are. Subcortical, cervical, Erb's point, and so on. These derivations all live in the red zone and require a lot of averaging, take a lot of time if you care to reproduce them. What we're after are the green zone of signals with the more than 10 decibel signal-to-noise ratio that consistently reproduce in less than 200 sweeps, usually in less than 100 sweeps, and very often less than 50. So we can obtain these optimal recordings in less than a minute in the vast majority of patients. So this is what the optimization is attempting to do. This is an illustration to show the optimization's benefit for monitoring. There's a peripheral and cortical response for each of the median nerves and each of the tibial nerves, and a muscle MEP from all 4 limbs. And the point of this slide is that we're cycling through all of these evoked potentials in a time of approximately 1 minute feedback interval for surgery throughout the surgery. Now, sometimes that can be a bit slower if there's other interruptions from electrosurgery and so on, but this is the kind of rapidity that one is after. And notice that the reproducibility is not compromised by using optimized SCP techniques. So this is a very nice kind of recording. This is routinely obtained in my practice now with this methodology. And the point of getting this fast as possible surgical feedback is quick diagnosis and intervention. So this is a scoliosis operation. I'm just showing 4 traces. The left leg SCP and MEP, the same on the right side. And everything is fine to this point. The surgeon inserts a sublaminar hook high in the left thoracic region. And within 1 minute of the last unaffected evoked potential, there's a sudden focal abrupt disappearance of the muscle MEP and a 30% reduction of the cortical SCP. You might say 30% is not 50%, so therefore it's not significant, but this isn't true. It's clearly visually obvious and is a clear reduction from the preceding SCPs. So this looks like an acute hemichord syndrome, likely from compression from the hook. So we took the hook out and the potentials all came back over the next few minutes. The patient had no deficit and we achieved a good curve correction simply omitting this hook. So this is what the SCP optimization is attempting to achieve and what it does achieve. The next issue is the warning criteria, and you are well aware, of course, that the traditional criteria are a more than 50% amplitude reduction or more than 10% latency prolongation from baseline. However, these fail to consider baseline drift or reproducibility, and they overstate the role of latency. To explain, intraoperative pathology causes acute neuronal or axonal failure. That is, there will be fewer elements contributing to the response, and therefore this will reduce the amplitude. This may or may not be associated with some latency prolongation, but an isolated latency prolongation, although characteristic and signifying subacute to chronic demyelination in the diagnostic laboratory, this is a pathologic process that does not occur during surgery. So amplitude, therefore, is the primary consideration and latency is only a secondary consideration and certainly not independent. Regarding amplitude, one has to consider baseline drift, which is a benign systemic effect that causes gradual generalized amplitude drift over the hours of surgery. It can go in various directions, but downward drift is most common and falls below 50% of the initial baselines in approximately 20% of surgeries. This clearly risks false positives if one rigidly applies the traditional criteria, and those false positives do not arise if you use, instead of the initial baseline, recent pre-change SCP reference values. Here's an example of baseline drift. Now, they're not always this marked. It's a particularly significant example of it, but these are plots of the amplitude of cortical SCPs from all four limbs, and you can see this gradual generalized downward trend, which reaches 80% reduction compared to the initial SCPs, and simply illustrates the point that it's meaningless to compare SCPs to an earlier baseline done hours before, which has no correlation to the current systemic state at the time that you're trying to assess a possible SCP change. There was no alarm and no deficit of this patient, and no alarm because we knew it was systemic due to the generalized gradual nature of the baseline drift. Pathological decrements are usually focal and abrupt. That's their hallmark characteristic, and it's the reproducibility that you've achieved in the recording that determines the magnitude of the reduction you need to be clearly non-random. Now, reproducibility is very important here, and as you know, SCPs are estimates distorted by residual noise, and it's the reproducibility that determines their accuracy. And reproducibility can be classified as high, medium, low, or non-reproducible, according to waveform superimposability and trial-to-trial signal amplitude variation. There are four SCPs. The first one at the top shows non-reproducibility because the waveforms diverge and the amplitude is varying by more than 50% trial to trial. The next one is low reproducibility with loose superimposition of waveforms and 30 to 50% amplitude variation. Then there's medium with approximate waveform superimposition and 20 to 30% amplitude variation. And finally, high reproducibility with nearly exact superimposition and less than 20% trial-to-trial variability. Now, obviously, if we want accurate monitoring, we wish to have these levels of reproducibility, which is what SCP optimization helps to achieve. Now, detectable decrements vary with this degree of reproducibility. If you're dealing with non-reproducible signals, they really have to disappear before you can say that there's definitely some kind of neurological change. If you have low reproducibility, then 50% might be appropriate. And then with medium and high reproducibility, you can begin to detect smaller decrements of 40 to 30%. This is very important. The traditional 50% criterion then is appropriate for low reproducibility, but risks false negatives with smaller decrements made obvious by medium to high reproducibility, as I showed in an earlier slide. And it risks false positives with non-reproducible signals if someone overreacts to a random amplitude change. So in fact, in daily practice, experienced interpreters do not take these traditional criteria literally, and instead they do adjust for drift and reproducibility. Therefore, the ISIN decided that we should make this explicit and recommend an adaptive criterion that is stated as visually obvious amplitude reduction from recent pre-change values and clearly exceeding variability, particularly when focal and abrupt. This approach reduces the likelihood of false results and represents actual practice and complexity. Now, if you encounter borderline decrements, they can be supported by more definite subsequent deterioration or by concurrent MEP disappearance. Here are some examples. This recording shows fairly good moderate to medium to high reproducibility and a gradual generalized downward baseline drift that does breach 50% of the initial baselines eventually. And it's punctuated by focal abrupt reductions of the right median nerve SCP. And this was due to brachial plexus compromise. The surgeon was pushing the shoulder into malposition, and it was corrected on each occasion by restoring a normal shoulder position. There was no deficit in this patient after surgery. Here's another example. In this case, the baseline drift goes in an upward, then downward, and then upward direction. And it's punctuated by an abrupt focal decrement affecting both legs. Now, the decrement of the tibial nerve SCPs in this is only 20 to 30%, but it is significant because you can see it. It's visually obvious and clearly exceeds the trial-to-trial variability of tibial nerve SCPs that had been established before. You might say it's not 50%, so it's not pathological, but you would be wrong. This patient awoke with bilateral leg sensory disturbances. He had burning dysesthesia of both legs. He could not tolerate things touching the skin of his legs. He fortunately recovered in a period of about 2 weeks and had no motor deficit. And in fact, there was no motor evoked potential change with this SCP alteration either. So I speculate that this patient had a dorsal column contusion during instrumentation. Here's another example of gradually rising, then falling, then rising baseline drift, and punctuated by an acute focal left tibial nerve SCP decrement of approximately 40%. This occurred immediately after placing a sublaminar hook, and it came back to baseline or the previous amplitude after removing the hook. There was no deficit in this patient either, and there was no motor evoked potential change with it. In conclusion then, the new ISIN, International Society of Intraoperative Neurophysiology, recommendations include SCP optimization and the application of an adaptive warning criterion. Of course, future advances could modify these recommendations, but that would represent the current state of the art. Thank you very much for your attention, and I'd be pleased to answer any questions if there are any.
Thank you very much, Professor MacDonald. I'm not what neurophysiologists we have today in our audience. But there is one question at the moment regarding the, just a second, signal to noise ratio. Just to find it. Yeah, so how do you assess signal to noise ratio before averaging?
You don't actually measure the signal to noise ratio. That's a more complicated thing that you have to do offline if you really want to measure the signal to noise ratio. So what you're doing is doing a preliminary recording comparing various derivations And by looking at how quickly they reproduce, then you judge which one is the fastest, and that will be the one with the highest signal-to-noise ratio by definition, essentially. So that's the approach. We're not suggesting that we should measure the signal-to-noise ratio precisely for each signal that we record. I think that would be very difficult, and the instruments that are available actually do not provide measurements of the signal-to-noise ratio. So it's a judgment call based on a preliminary assessment of the various derivations that are possibly optimal in an individual.
Thank you. Could I maybe ask you what about the preoperative assessment of some neuro?
Sorry,
to do before.
There's some interruption. I can't hear your question.
Okay, can you hear me now?
Yes. Try again.
Okay, my question. Okay, so let me try again. Yes. Is there how useful it is to perform the neurophysiological assessment before the actual operation, so to get some baseline?
Yeah. Well, I used to routinely do that. I practiced in Canada and Vancouver for 10 years before I moved to Saudi Arabia. And it was just routine. We just had every patient assessed prior to surgery as part of their pre-admission workup. We'd examine every patient and do an SCP, brainstem auditory evoked potentials. We weren't doing MEPs prior to surgery. And it gives you a chance to see the patient, tell them what's up. They've been familiar with the techniques. They're not disturbed by it when they get to the operating room, and they know what the realistic expectations of the monitoring are. And you know what the potentials look like. But honestly, I found anybody with a normal neurological examination, really, I mean, the evoked potentials are normal, and it doesn't really alter what you do in the operating room. It can be helpful in patients with neurological deficits who have perhaps absent SCPs. And in that case, I've never been successful in obtaining intraoperative SCPs if the SCPs are absent before surgery. And that can save a lot of effort on the day of surgery, because you may simply omit the SCPs and try to do motor evoked potential monitoring alone, for example. And in my current hospital, it's just structured in a way that there's no way to organize preoperative evaluations on a routine basis. So it's very rare that I get a chance to do any preoperative evaluation. It's normally a call in the afternoon for a case tomorrow morning, and you know, it's just not feasible. So I've had to adapt to that, and I honestly, in patients with normal neurological function, I don't miss preoperative baseline SCPs. There are occasions when they're absent, and I wish that I had had SCPs before surgery, and I wouldn't have had to go through all that effort. So if there are neurological symptoms, signs, or deficits prior to surgery, I think it's worthwhile. Otherwise, it's not really that useful.
Thank you. What about, are there any cases where the responses would increase during operation, like when?
Yeah, this is an interesting question. It's a very good question, and I think it can happen. I don't think it happens very often. I think it's reported to occur more often than it actually does. If you think about it, I mean, if a patient has a chronic neurological lesion with abnormal evoked potentials, I mean, why on earth should we expect that, say, decompressing the chronically compressed spinal cord, you would suddenly see, you know, a resurgence of SCPs and the restoration of normal conduction? I mean, it just doesn't make pathophysiological sense to me, and I've never actually seen that. There are reports in literature of this kind of thing happening, but really I don't recognize it. I wonder if people are overreacting to minor changes of amplitude with poorly reproducible signals, because I see a lot of questionable interpretations of not so reproducible data, and I think sometimes people get overly enthusiastic about this kind of question. On the other hand, if you have some kind of acute neurological malfunction causing SCP abnormality, say acute spinal cord compression from spinal trauma or something like that, then it might be reasonable to think that if you relieve that, you could see during surgery a restoration of normal conduction and an increase in the amplitude of the potential. And I honestly, I can't think of a case where I've actually seen that. But then I've never had the opportunity to be monitoring in acute neurological situations. This is usually, elective surgeries for chronic tumors or scoliosis or, chronic spinal cord compression, these kinds of things that I'm not expecting to see a big increase in evoked potential amplitudes during the actual surgery, and I don't see it. Maybe I'm biased against it, but it doesn't make physiological sense to me. Maybe it could occur in an acute neurological problem that you're monitoring.
Thanks. We have another question. What about preoperative versus intraoperative MEPs in a patient?
Oops. I've lost your question.
Maybe I can try again. So I'll switch off my video. Yeah, okay. Preoperative versus intraoperative MEPs in a patient with preoperative weakness, a walking problem.
Yeah, I've done it on a few occasions, but the problem is that it's a very different stimulus, isn't it? I mean, transcranial magnetic single pulse stimulation, awake subject, and pulse train stimuli, transcranial electric at intensities that you can reach that you can't really apply to awake subjects. So I've seen patients with absent preoperative MEPs who you are able to obtain intraoperative MEPs. So I wouldn't be able to say, let's not do them because the preoperative ones are absent. It's just too different a technique. And you can't do the transcranial electric stimulation as a preoperative baseline because it's simply too uncomfortable for an awake subject. So they're much less useful, and I don't see people doing that very often.
Okay, thank you.
You're welcome.
With my connection. So thanks a lot for your lecture.
You're welcome.
Thank you for joining us.
I was in Slovenia once, by the way, some years ago. There was another one of these annual neurophysiology meetings, and it was about intraoperative neurophysiology. So I don't know, it was in the early 2000s. A beautiful city, and I really enjoyed it.
So unfortunately, this year is slightly different.
Well, everywhere is a little different this year, isn't it?
As a speaker.
All right.
Yeah. Thanks a lot. Bye-bye.
Bye-bye.